founder and CEO of Cannabis MD. Welcome to another Cannabis MD video profile. Today I am joined by Dustin McDonald, who's Interim Policy Director of Americans for Safe Access. Dustin and I are going to be diving into, as best we can, a 180-page report of the state of the states. It has so much information in them that we're going to be talking about Dustin's role in this, the information that is included in this report, and the purpose of its valuable content. This report has been used since, these are generated on an annual basis and have been used since 2014, I think is the first report, by patient advocates and policymakers as tools to assess and improve state medical cannabis programs. So it is very robust. Highly recommend that folks download it, take a look at it, and has this phenomenal comparison of these the different categories that states are assessed on and graded from an A to an F. So it's fascinating. Welcome, Dustin, to Cannabis MD.
Thank you so much, Jackie.
So let's see, Dustin leads ASA as the acronym that Americans for Safe Access is known by, as the freelance policy, government relations, and public affairs expert with over 20 years of experience in advocacy. Prior to his work with ASA, Dustin spent 3.5 years at Weedmaps, where he built and managed a 20-person international policy and government relations team, and guided associated federal, state, local, and international engagements on cannabis policy issues. I would have loved to have been flying on those walls. He joined Weedmaps after serving 3.5 years as the director of Government Finance Officers Association, that's a GFOA, Federal Liaison Center, where he led advocacy on municipal finance issues for a coalition of state, county, and city government associations. At GFOA, Dustin also served as lead staff on its Committee on Governmental Debt Management, working with committee members to develop best practices that promote sound financial practices for state and local governments. So Dustin has served a variety of successful advocacy campaigns on a diverse group of issues. All sorts of focused municipality, finance, tax reform, multimodal transportation, related infrastructure, telecommunications, public safety, manufacturing, and there is more. So welcome. And, always lead off with, your role at Weedmaps, was that the first role in the cannabis industry?
Correct, yeah, so jump right into the fire.
Yeah. And what led to that role and that getting into the cannabis industry? What was the purpose and interest?
I think it was a kind of a twofold opportunity. I'm a native of California and was interested in getting back to California after working in Washington, D.C. for about 15 years, and had an opportunity emerge to work for Weedmaps, building out their government relations practice that would be multi-state in nature, as well as advocacy at the federal level and some international work too. So it's a gigantic portfolio of work that was very exciting to work on. We built a lot of really interesting and innovative strategic campaigns, really designed to influence policymakers and get them to understand. I think that's a challenge that we can talk about some today, but there's a huge gap of knowledge between what's actually happening on the ground and folks who are operating on the advocacy side and the industry side versus what lawmakers know and understand about what's happening in this space and what's real and what's not, what's myth, what's fact. And so we spent a lot of time building functional campaigns designed to educate, more than anything, lawmakers on the state of play and really where things were, to give it a strong understanding about how that works so they can make actionable decisions on it that would actually improve policy outcomes, not just for industry, but also obviously for patients and consumers. My interest in kind of jumping into that, besides just wanting to get back to California, I have a chronic health condition that I struggled with for a really long time. One of the biggest challenges associated with the condition was sleep. The disorder kind of robs you of your sleep. And that can have a really negative cumulative effect over time, not just in your ability to recover, but also in just your ability to function. So
Sure.
I ended up having to navigate a lot of traditional FDA approved products to try to achieve sleep as well as deal with some of the other issues related to the disease. And ultimately came up short on all that stuff after years and years of trying to utilize these traditional approaches, and had to try to come from a different angle. And I think that's probably a case for most patients that are patients who are utilizing cannabis. In most cases, they've tried everything. These are not simply cannabis patients versus pharmaceutical patients. They've tried the pharmaceutical route, the FDA approved route, and for whatever reason, those have not been sufficient to really address their health issue. And so I had the same challenge, and that really kind of led me to some interest in working in the space. And I think following the work at Weedmaps, which, we really try to drive a lot at advocating for patients as well. But I think working for Americans for Safe Access is exciting because, you get to work directly for patients. It's not a broader agenda. This is what we're working on. We're working to advance knowledge about what is appropriate and functional policy, so that the policy that's built at the state level by lawmakers or regulators, once it's delivered and actually out there in the field, it functions and works for patients in both delivering access, keeping patients safe, and ensuring that patients are utilizing a system that's efficient and helps address some of their challenges related to mobility and cost.
Yeah, I had the phenomenal opportunity to lobby Congress with ASA a couple of years ago, and how impactful to spend time with patients who, there was the challenge of being able to access and medicate during the day. Obviously they're on federal property. So you well know that. And I'm curious, as moving forward in the age of COVID, what's lobbying look like?
Lobbying is a very strange world.
Yeah.
The traditional world of lobbying is all built around all these little meetings, whether they're
Right.
One-on-one meetings that you have at a congressional office and a staff office, whether they're meetings that you take outside of those offices and you have coffee or lunch with folks. None of that's possible right now. So the entire world of traditional lobbying is kind of a little bit disjointed. So now it's just, as you and I are having this conversation, this is how traditional lobbying takes place now. It's a digital format where you might have a chance to hop on a Zoom call with a staffer to educate them on an issue.
Yeah.
It's a lot of the same approaches, whether it's individual meetings or coalition meetings, only it's all either going to be over Zoom or on a phone call. So there's a lot less of that direct personal interaction. And I think, it's kind of strange. You're in a time when there's the greatest focus at the federal level on cannabis policy reforms than there ever has been. You've got bills like the Safe Banking Act having passed the House. You've got legislation moving to the floor like the MORE Act that we expect to see a vote on before this year wraps up, likely in the lame duck. So it's the time when there's the most focus on this issue that's been so critical for so many patients for so long, having meaningful federal engagement on it to address the scheduling issue, which will untangle so many challenges that exist between federal and state conflict of laws. While all that's going on, we're in this situation where we can't lobby in the way that we're all used to and be effective in the way that we're all used to. So we're kind of having to reassess how all of that works as we drive into 2021, when there could be considerable focus on this issue again in the coming Congress.
Yeah, I mean, I would imagine the challenges and you have to have some unique skill sets to be an effective lobbyist in this digital format. So
definitely.
Yeah, it's fascinating. And to your personal experience, and thank you for sharing your personal experience with cannabis and how effective it's been for you. And that is, I have found those that are most, I think, making the most progress and are forceful in the industry and helping to make change are those that have this personal connection. And if it's not with them, of them being a patient themselves, it's certainly more stories of family members. So, again, I thank you and respect you for sharing that.
I think there's a lot of value there too. I think while certainly there's a powerful group of industry operators who have secured contract lobbyists to help them carry their water in the district as well as at the state level, at various state levels, to try to advance policy. Really nothing moves the needle quite like direct patient engagement with their elected leaders, where you can go to your elected leader and talk about the world you're trying to navigate as a patient, juxtapose that for your lawmaker with the world they're used to seeing if you're a patient of a pharmaceutical product, driving through traditional office visits with your doctor and then going to the pharmacy to pick up your prescription. You introducing them to the world that cannabis patients have to live in, which is a vast departure from that FDA kind of Western medicine paradigm model, I think is very powerful in getting lawmakers to understand, oh, wow, there's some real issues here that need to be fixed. And it's not just this patient who's talking to me. This patient is also telling me that there are hundreds of thousands of patients who are experiencing the same thing across the states. There's a lot more work that needs to be done here than the limited work that has been done.
Yeah, and so I have found I've done lobbying, as I said, with ASA in Congress, and then spent a fair amount of time in Annapolis, state capital of Maryland, where I am. And so you have effectively been lobbying in the cannabis space since 2016, is that right? Since you were with
Correct.
Yeah. So I have found, it's incredible that the folks that are making our laws that we vote in, how little they know.
Yes, I mean, it's it's remarkable. I mean, I did a lot of state by state lobbying across the states. I mean, the campaigns we ran at Weedmaps, we ran advocacy across 10 states plus federal government plus 5 Canadian provinces. So we touched a lot of governments, and across all of those, not just state and fed, but also locals, you really realize that many of the same issues. I mean, look at Canada, I think provides the perfect example of this. Mm-hmm. When you go to talk to a state lawmaker here in the States, or you go to talk to a local lawmaker about organizing additional reforms or addressing some of the challenges that exist in these systems, you get a lot of pushback about the conflict between federal and state laws. You'll have state lawmakers telling you, well, I'm not really dialed into this because there's that conflict of laws. Until that gets addressed, it seems like these systems won't work all that well. And they're not wrong. Then you have local lawmakers who will just tell you, we're not even going to organize local policy reforms to enable patients to have access because of the conflict of laws. We're worried that the federal government could step in and cut off federal pass-through dollars that they receive, money for things like community development block grant, COPS funding, fire grants. These are all federal funding streams that flow to local governments, and locals are worried about losing them. Okay, look up in Canada now, you have a fully sanctioned system from federal all the way down to local, mm-hmm. and there's a nexus of laws all the way from the bottom to the top. Even in that system, you have many of the same issues remaining, which are really based primarily in stigma. There's a tremendous amount of stigma associated with cannabis possession, use, and sale that really has been a hallmark of how governments have dealt with cannabis since the early 1900s up to now. And so it's going to take a long time to remove that stigma and educate lawmakers about what cannabis is and is not, the dangers that it may or may not have, and the truth about what patients need and what's still missing in these systems. It's going to take a while for all of that to work in a meaningful way because of that education gap.
Yeah, it's remarkable, but here, and this was in the ASA report too, of with cannabis, nobody's died, and the stigma and that surrounds it, that continues to surround it. Again, these laws, whether they're U.S. based and my experience international, they're founded on racial prejudice, and it's just it's remarkable in a most negative sense that it's so slow to move, and people are still remain fearful. But when you were talking about the limitations on lobbying, I immediately thought a few things, but who stands in the way of the cannabis industry to moving forward? And are those groups going to be as effective as they have been in putting walls up for people to have safe access to the medicine? Do you have any comment on that?
For sure. I think the fundamental issue in terms of getting lawmakers to change their positions and how they approach cannabis policy, mm-hmm. there are a couple of factors that influence that pretty heavily. I think the first is the status of policy in their own state, if we're talking about federal lawmakers. So if you're a member of Congress or if you're a U.S. Senator and you live in a state that hasn't organized functional reforms for medical or for adult use, then you're really not paying attention to this issue. This isn't an issue you're concerned about really at all. It's not something your state is dealing with. Of course, the map for states that have functional policy is expanding, or states that have policy organized at all, any kind of reforms on cannabis is expanding. At this point, you've got 47 states online with some form of access, 11 of those plus the District of Columbia with adult use, and 33 with fully functional medical models. By that, I mean, these are systems that either have a pretty expansive list of qualifying conditions for which patients can use to obtain eligibility, or they've removed that list entirely and are letting physicians decide, oh, this patient is an eligible patient for cannabis or not. Under those systems, patients typically have much more robust access. It's an easier system to navigate for patients than the CBD-only model states. So I think that's the second piece really is, if you're a state lawmaker if you're a federal lawmaker that's from a state that doesn't have access, then you're just not going to deal with this issue. You're going to be probably an obstacle in the path of federal policy reform. But to the point about the map expanding, I think the more states that do bring cannabis policy reforms forward, that puts their federal lawmakers in a position to pay attention to these conversations and start to get informed. And that really kind of leads us to the next piece, which is, where does the information come from? And I think, as we talked about from your last question, that remains an ongoing challenge. I think one of the things that we learned very quickly in building an advocacy team and advocacy approach at Weedmaps was, there's not really a wise old man out there on cannabis policy reform. As we would move from state to state, as ASA talks with different states, many states have asked us which state has organized the best policy reform model, which state did it best. And the answer really is that none of them have. Some states have a piece of policy that's more functional than another. And other states have a lot of work to do in building out a fully functional system that actually delivers to patients the access, the safety, the legal protections that are really built into the design. Often those features don't make it to the road where it meets patients' feet. So I think that level of education is something that has to be built and has to be pretty repeatedly delivered or delivered with great frequency to lawmakers and their staff in all different kinds of forums. So it's not simply advocacy letters about a pending bill. It's direct engagement with lawmakers when they come back home to the district. It's going to talk to them at their town halls. It's meeting with their district staff to inform them about specifically what's happening with cannabis as a medicine in their district, so they start to understand what's really going on. And I think patients have to be that voice. Groups like Americans for Safe Access are that voice. And, we built a strong army of patients, of practitioners, of providers who partner with us both at the federal level and the state level to try to drive those reforms that really come through education. And it's really only through that education that you're really going to be able to get at those obstacles of those lawmakers who are kind of standing in the way and kind of working at and around them.
Yeah, and so speaking about education, that's pretty much the purpose of Cannabis MD, is to provide education, particularly that is void in the curriculum for healthcare providers. So, jumping into that, what can, let's focus on physicians for a moment, and then I want to dial it back and talk more about the report. But particularly, physicians need to be educated about medical cannabis. The patients are what we have, just over 4 million patients now, I believe, in the U.S. And looking at data recently that I think it's 9% of the 154 medical schools in the U.S. include cannabis science education, or cannabis education for something other than looking at it for a use disorder. So there's just such a disconnect on what Americans are asking for, using for, and then to have truly what ACE is all about, is safe access. So what do patients, maybe this is a better way to ask the question, or it's a more important question, what should patients be saying to their physicians to get them engaged in understanding the impact that they have in changing policy?
It's a great question. First, I'd offer up that ASA has a resource that drives directly at this, which is how to talk to your doctor. And I think, through ASA-led programs like Cannabis Care Certification, Patient-Focused Certification, the PSC and CCC programs. These are programs that ASA runs directly to try to help educate physicians and practitioners about how to have these conversations with patients about what the status is of state and local federal regulations as they pertain to that medical practice and its engagement with patients who are utilizing cannabis for treatment. So there's a whole suite of great resources that ASA offers to educate both practitioners, medical practitioners, as well as folks on the industry side who are running businesses that are either cultivating or manufacturing or testing or retailing these products to medical consumers about kind of the know-how that patients are going to expect them to have if they're going to be serving them. So there are those resources, but with respect to how to talk to your doctor, I would definitely recommend that patients check that guide out, because I think it's very helpful. As a patient myself, I know very well these conversations are very difficult to have with your doctor, especially depending on where you are. Some doctors are going to be more or less educated about medical cannabis. But I think one important thing to remember about physicians' education about all of this is physicians, just like any other professional, typically belong to a national or a state association of like types of physicians.
Right.
And that's often where those physicians will take their cues about specific state policies and how they might impact their practice and whether or not those physicians are going to engage in that and doing work in that policy area based on that impact. I say all this to say that, there are national associations of physicians. There are national public health associations whose members are cities and counties that are in states that have fully functional medical cannabis policies. Many of these associations have not enunciated any position whatsoever on cannabis as a medicine. And if they do so in a way that's very non-committal. That's a huge problem, because if your state lawmakers and regulators are saying, we have a medical cannabis program that patients can access, but the state's Department of Public Health and associated county departments of public health don't subscribe to that belief, then you have a huge disconnect that's directly going to impact patients, where you can't get local county departments of public health to buy into these systems, then patients aren't served. So there's a tremendous amount of work that needs to be done to educate physicians, starting that conversation to the extent that patients are able to have it, utilizing ASA resources like How to Talk to Your Doctor. It's a very helpful guide, because I think it helps patients think through in having that conversation. One, how are you going to talk to your doctor about an issue where there's a ton of stigma around it, and you're trying to talk to your doctor in a way that one, demonstrates to them that this is something you legitimately need. You need access to, it's effective for you, and the traditional pharmaceutical approaches aren't working. And that's a difficult conversation to have if you have a doctor that may or may not be really subscribing to any of that kind of thought leadership. In those instances, look, as somebody who has a chronic health condition, who's had to navigate a ton of doctors, I like to tell other patients that, look, going and getting a doctor is like going and getting an auto mechanic, right? Most of them have a basic understanding about how the machine works, but they may have very different philosophies about how they practice medicine. If your doctor is not a doctor who is willing to work with you, find another doctor, is what I would say. There's a tremendous need for doctors to understand the true impacts of cannabis as a medicine for patients, in both alleviating symptoms as well as, in some cases, eradicating specific diseases. So obviously there's a lot of research that needs to be done out there to provide U.S. domestic verification of all that science that's being constrained by the conflict of laws between federal and state right now. Still, there's a ton of anecdotal evidence that patients have experienced themselves, and they know it's effective and what isn't. So yeah, I would definitely recommend that patients educate themselves using ASA resources before having that conversation with their doctors. But should that conversation not be successful, I would not tell patients to give up there. I would definitely recommend that patients continue working to find a doctor to treat their health, just like they would find an auto mechanic to treat the health of their car.
Yeah, and that's a pretty simple model to follow. And yeah, and there's consideration, we've been using this phrase, a medication of last resort, which it shouldn't be,
Right.
is that's absolutely that needs to be changed. Is that it's a yes, it's I regularly say cannabis is not a panacea. It does not work for everybody, but yet it is absolutely worth investigating and considering and consideration as an adjunctive therapy. So yeah. So
Agreed. When you have a medicine, I think that's what's challenging about cannabis for traditional medicine is that it has a broad suite of applications, from everything from alleviating anxiety and minor pain to ongoing chronic pain and acute pain. Within that, there's a whole host of disorders, of health disorders that can be addressed through either ongoing use of cannabis, microdosing, small quantities over the course of a 24-hour period. These are doses that in most cases don't arouse any kind of psychoactive effect on the patient. I mean, it's such a broad array of applications and disorders that cannabis can be effective in approaching, that I think it's difficult for traditional medicine to immediately dive into it, because they're very used to, we built this pharmaceutical product to treat this specific health condition, but it's also a one-size-fits-all model. It doesn't allow for any deviation in the caseload. One patient might be affected in only a minor way from that health disorder. Another patient may experience a whole suite of other symptoms and other health issues related to that health disorder. So there's a tremendous amount of diversity often in cases of a disease. And I think traditional medicine doesn't really allow for a lot of deviation from a specific treatment for a specific type of disease, where I think cannabis allows for more of a broader approach to treating a health condition that recognizes that these health conditions and their associated treatments really aren't one size fits all.
right, everybody's 100% of the population has a endocannabinoid system, and 100% of the population's ECS system does not operate the same.
Right.
Yeah, and to the pharmaceuticals is that there is the off-label use, so that they have been formulated to treat a specific disease or disorder, but then, this I don't know is how it's the research leads to that it has a particular pharmaceutical product has a use in another area, but yeah, and then that goes to what we're talking about is this myriad of conditions, qualifying conditions, and
Right.
looking at state by state. And this again, going to the report, which really underscores that there's no uniformity from state to state and on things, including qualifying conditions. So they're looking at this report. So there's 180 pages, and the states are judged, again, receiving a grade from A to F. We're looking at patient rights and civil protection from discrimination, access to medicine, ease of navigation, functionality, and consumer safety and provider requirements. And with that is that each state was scored on how well their current laws and regulations accommodate patients' needs, as broken down by these 5 different categories. So yeah, so much to dive into.
I know there's a lot. I mean, like you say, even underneath those 5 categories, there's a myriad of subcategories that inform those major categories that really results in the final score. But that kind of gives you the highlights, when it comes to your point about the tremendous amount of deviation between the state policy models. I think that's those scoring categories are a great place where all that's really fleshed out. I mean, you can see with respect to patient rights and civil protections, that's a huge one. If I'm living in a state that tells me, a medical cannabis patient, that it is organized an access model for me that both will allow me to register with the state as a patient, they're going to protect my information or not, because some states don't. The states aren't going to protect your information or allow that information to be shared with, say, law enforcement agencies. You could lose simple civil protections that most people are used to. You could lose your Second Amendment rights. If you're in subsidized housing and you're a cannabis patient and you want to enroll in a state program or utilize cannabis where you live, in the place where you live, that can be challenging if the states haven't organized specific policies protecting patients as renters of apartments or of homes. So that can be a challenge. And then there's employment. You know, a state can tell somebody, okay, we've organized the medical access program that's completely legal. Oh, but wait, your employer can still fire you if you fail a cannabis drug test, or you won't be permitted to use cannabis at work, even though you may need to microdose during the day to alleviate the symptoms of your disorder. So there's a tremendous amount of deviation on simple things like that. It baffles my mind, I'm sure it does of most patients, about how a state can organize a program that seems to, on one hand, extend access, and on the other hand, directly threatens those patients for engaging with that access by, you know, risking the loss of employment, housing, family protections, which means you could lose your child in a custody battle. So there's a lot of legal protections that states need to be thinking about how to organize while they build these programs out and put them out there for patients to access. California is a state just like that, where, you know, I live in California now. California's a state just like that, where you've got no employment protections in place for patients. And so this is a state that's had a collective model since 1996. Of course, they scrapped that in the start of 2019 for a full-scale adult use model. So you saw a lot of negative ramifications of that. There were a lot of medicines that were existing and born from those collectives that are now gone, that patients don't have access to in any meaningful way. But yeah, to the point, California is also a state where I can be a medical cannabis patient, but my employer can still fire me for being a medical cannabis patient. So I'm being penalized for participating in a state medical program.
Yeah, and the report, what I think is also fascinating is there's, I don't know if it's part of the summary or conclusion, but that highlighting particular states that are doing very well in a particular area. So Maryland, I was very proud to see, and certainly because I know the folks that are leading the commission on, I think that was the only state to have 100 on the regulations about patient safety. And then it was...
That's a huge one, right? I mean, that's a gigantic one, right? Because I mean, I think a lot of states don't think about that either. I can't tell you how many regulations we read through where you'd see a state have specific policies in place for different industry providers across the supply chain, from cultivation to manufacturing, through lab testing to retail and distribution. But on the lab testing side, there either weren't sufficient regulations put in place for everything that the labs were supposed to be screened for on the toxicity side. So heavy metals, pesticides, molds, contaminants, either they didn't have a full picture of all those pieces that they need to be testing for, or they weren't testing for them to the degree necessary. And that's a challenge for states. I mean, I'm not trying to beat up states in saying that. I think it's a very big challenge for states because that's a piece of law that rests at the federal level. That's Department of Health and Human Services. That's Department of Commerce, National Institute of Standards and Technology. I mean, these are the federal entities whose job it is to oversee those types of regulations and understand specifically how much of a contaminant could impact a human's health. This is not something that most states have any kind of capability in traditionally. So it's a challenging area for states, but it's a very important one, because we don't just want to measure for across those things that could harm a patient in terms of what could be present in a medication, but we also want to let patients know what is in the medication. I think a big challenge for states, for patients in navigating these systems, is they're really left on their own to figure out what works for them and what doesn't. To your point about that we had earlier about conversations you have with your doctor, you may have a physician that's working with you, and hopefully you can find one that will, but you may not be able to find one that will, and you might have to just kind of figure all this stuff out on your own, which is challenging. But I think for a lot of patients who are in the space of utilizing cannabis for treatment, they've tried a lot of other things, and so they're probably on this journey already by themselves a little bit. But you know, patients need to understand, okay, you screen for all the dangerous stuff, and I know it's not in there, but then we also need to understand, did you screen for the total amount of plant compounds that are in this medicine? How much CBD, CBG, CBN is in this product, THC? What is the proportion of each of those compounds that's in this product, as well as the terpene profiles? Because ultimately, that combination of plant compounds and associated terpenes is really what delivers that entourage effect that really speaks to the effectiveness of that specific type of cannabis medicine in treating any individual patient health conditions or the underlying disorder. So yeah, plenty of room in there to mix things up, and it's exciting to see states like Maryland get it right.
Yeah, and there's lots that I would like to continue to ask you about policy, because I also am a policy geek as my undergraduate. So looking and data with economics, but yeah. So shout out to Lori Dotson, who is now deputy director, but she was heading up the labs. And as states are going to, and particularly with the impact of COVID, and more conversation, it's states may be speeding up to be launching adult use markets and programs. And looking at, there was some data that I was looking at today about the dollars of revenue. I don't know how they figure this out, but from the illicit market. And so how to, in one particular state, and I think this state also got an F from ASA, is Texas, and leading in the illicit market revenue. And yeah.
Huge challenge there. And I could talk for hours about this one. So particularly, this is a big point for me. I think the issue of access is an issue that requires a multi-level government approach. A state can pass a policy that enunciates the extension of access, of safe and legal access of cannabis as a medicine to patients. But if nothing is done to facilitate that access, either at the state level or at the local level, which we'll talk about in a second, then patients won't really actually have access. There are a number of states that I think we called out in the report that have this issue: Massachusetts, California, Delaware. There are a number where this is a real problem. In some of these states, you wouldn't expect to see that kind of problem, California being one. You've got 482 cities and 58 counties here. Across all those cities and counties, keeping in mind that the state passed comprehensive medical access back in 2015 and had a previously existing collective model operating since 1996. So the phenomenon of cannabis access on the medical side in California should not be new or foreign to voters or constituents. However, that's the exact state we're living in today. Across those 482 cities and 58 counties, 2/3 of them do not provide safe and legal access for medical, meaning that patients in all of those communities are really left with no safe and legal access place to go and are relying on the illegal market for the access they need.
Right, and we go back to the testing, that these products and how dangerous they are and that they can be contaminated.
Exactly, and I think it's a real challenge. I think, that patients are in right now is one, if you participate in the legal market, you're likely experiencing higher costs. Even if you're shielded from taxes on the product, the thinking around organization of regulations for the cannabis industry in most cases isn't defined well enough to really help patients in that way. In other words, costs are being added through implementation of regulations, which are increasing costs for these businesses, everything from cultivators all the way to retailers. And those costs over the course of the supply chain are being directly transmitted to patients. So if you're participating in the legal market, you're likely experiencing much higher costs than you would by buying off the illegal market. However, to your point, on the illegal market, there's absolutely no safety and testing requirements put in place. But I would also say this, on the state models, many of those state models, as we talked about a second ago, they're not particularly proficient at organizing functional regulations for laboratory testing. And worse, some of the lab testing requirements are phased in. And so an operator who's a cultivator or manufacturer who's actually building a product for medical patients may see a phase in of regulations before they have to really meet stringent testing requirements to keep patients safe. So that's a challenge for the state models as well, is not only not totally understanding all of what they need to be testing for, but phasing in those requirements to help drive down costs for industry operators. However, the final product that may be delivered to a store shelf for that patient may have an inadequate kind of testing in terms of the total volume of whatever needs to be testing for to keep that patient safe.
So we talked about, and wrap this up, the patients, the providers and, of course, the government agencies, both at the state level and at the Fed. So how about the industry itself? How engaged have the owner-operators and these multi-state operators, the MSOs, been with ASA and supportive of ASA's initiatives?
Industry is right there with ASA and advocating at state levels, at local government levels, as well as at the federal level for reforms. Certainly, you've seen a tremendous increase in the volume of dollar resources being spent. I think there was just an article in MJ Biz Daily recently that covered this, that talked a little bit about how much individual associations are steering to federal and state lawmakers as they try to educate them and engage them in supporting advancements of additional reforms. So there's a lot of that going on at the industry level, which I think is very powerful. I think that combination is really a perfect one where coalition agreement can be met on what's being advocated for, because I think for associations, I think the strength of associations is really in numbers, is in how many members they have and where those members are, so you can strategically use a group of members in the state you're trying to advocate some policy reform in to drive at that reform. As we talked about earlier, it's very effective for a patient to meet directly with their lawmaker in the district or up in their capital office and talk with them specifically about the experience they're having as a patient in navigating a state system. And same thing with a federal lawmaker and getting them to understand what patients are dealing with on the ground and the need for the federal reforms. And I think those conversations are key to turning the tide in a lawmaker's mind about moving from a either ambivalent position to a support position in patients, or I think simultaneously it's important for patients to maintain that level of engagement with their lawmakers and also be understanding how they can be working with industry and how those groups work together. Because on the industry side, they can do something that a lot of associations can't, which is give directly to elected leaders through political giving, through charitable giving. They can provide direct contributions to lawmakers and have the resources to do it. So I think the combination of bringing lawmakers financial resources that is a traditional part of advocacy. Most associations don't have deep enough pockets to spread that kind of money around. You're talking about giving in increments of anywhere between $5,000 and $10,000 at a time. Multiply that by 500 or so members of Congress. That's a pretty big check you've got to cut off. So having that combination of industry who can really be there on the financial resources side in working with lawmakers, plus kind of folding them into coalition advocacy with associations, I think is really the most powerful combination. And certainly industry is there engaged and plugging into those discussions.
All right, well, thank you. So we've hit the patients, the providers, the industry, and I'll focus on advocacy for safe access and access, period, and to quality cannabis medication. So Dustin, thank you so much for the generosity of your time.
Oh, for sure.
We can keep going and look forward to talking with you at another time. And it's funny, my dog and your dog, I think, are on the same clock that it's time to go. So
maybe that's what she heard. I don't know.
Yeah, thanks again.
Thank you so much, Jackie.
All right, take care, Dustin. Bye-bye.
All right, you too. Bye-bye.